Hello, and welcome to another episode of Carnivore Evolution. I'm one of your hosts today, Victoria Olson. We also have with us Peter van der Plas and Tony Stewart. And our guest today is Dr. Robert Cywes. Before we begin, hello, Doctor. I'd like to make a brief announcement today in remembrance of a longtime pet and companion, friend of Mark Ennis's, who's not with us today because we lost his dog Rocky, and he's pretty broken up about it. And we just wanted to remember Rocky and send our condolences to Mark in absentia here. All right, now let's get on with it. Dr. Rob Cywes, we know you as the Carb Addiction Doc. We'd really like to hear about that and how you came to become the Carb Addiction Doc. You certainly were in the vanguard with that concept. And if you would, please tell us about that.
Well, I think, it's a multi-pronged approach to getting to that point. I've been doing this since I started my PhD in 1990 in Toronto. So it's been a very, very long time. And that was the high time of the anti-fat movement and the pro-carbohydrate vegetarian movement. So in fact, it's interesting, I did my PhD on liver metabolism with a guy called David Jenkins, who is a fastidious vegan, but he is the guy in 1981 that wrote the seminal work for the glycemic index by which we manage they manage diabetics. And so that was kind of the face of what we were looking at. I personally have a journey of having been and still battling for the rest of my life, obesity and my relationship with carbohydrates, my management of my emotional needs. And we can talk extensively about that. And then the other part also, as a physician, as a scientist, we exist as human beings because of carbohydrates. Without carbohydrates, we do not exist as a species historically, evolutionarily. So why now suddenly have these things that have created us and taken us to the forefront, to the apex of the mammalian and the earthly world, why are they suddenly causing harm? So the first statement, and the thing that I've found, is that carbohydrates are innocent of any wrongdoing. Okay, let that sink in. Carbohydrates do not cause any problems. It is our relationship and the transformation in the purpose and the manner in which we use them and the way that we concentrate and process them that causes the problem.
Yeah.
So it is the causation is related to a shift away from primarily eating food for the nutritional value toward patterns that align with eating primarily for the endorphin value. And that chronic excessive consumption of carbohydrates, of snacking. A snack is, as it says on my coffee cup, I don't know if you can see that, but it says a snack is always an emotional event, of binge eating. Those are things we do for instant gratification, for emotional restitution, rather than for nutritional value. But we became trapped in obesity and diabetes being nutritional problems. They're not food problems, they're drug problems. We recognize that easily with alcohol. Alcohol is not a hydration problem. When somebody says, oh my God, I'm thirsty, an alcoholic says, oh my God, I'm thirsty, it isn't because they're dehydrated typically. They're asking for emotional relief. Their drug of choice is alcohol, and their expression, their personal recognition of the need for that instant gratification that alcohol provides is mediated through the sentence, I'm thirsty, I need a drink. But they're not looking for water, they're looking for whiskey. When an obese person like myself says, oh my God, I'm hungry, it is never because of nutrient deficiency. I have very successfully beaten the disease of anorexia. The driving force is not my low selenium levels. It's my brain saying, I need relief of emotional tension. I need to put something in my face. And the drug is carbohydrates, and the pattern is a combination of snacking and binge eating. And that is an observational association that became very evident within myself and within the patients I treat. And so that is the evolution of the concept. Now, the final thing I'll tell you is there is use, abuse, and addiction. Not everybody is a carb addict. Not everybody has to stop eating carbohydrates. I've got plenty of, if I go out and I get hammered one night because I drank too much alcohol, but I wake up the next morning and say, ew, that was horrible. I'm not going to drink for a month. I've abused alcohol, but I can still drink. I don't have a broken relationship. But if I've had 5 DUIs and I've got liver disease and I wake up the next morning after a binge and I need whiskey to make me feel better, that relationship is broken.
Yeah.
Okay.
Mm-hmm.
And
how does that?
Sorry.
Just a quick question. How does that compare with, for example, a person that drinks like 1 or 2 glasses of wine a day? Let's say the non-alcoholic.
So
where do you place him?
Very good question, Peter. And the problem, you see, you can't quantify harm, because for some people 1 or 2 is a beneficial issue, like a lot of Europeans. And my son lives in Paris, and Paris wouldn't exist if it wasn't for a glass of wine at lunchtime. But the point is, you've got to quantify it by harm. So here's my definition of addiction. Addiction is chronic excessive use of a substance or an instant gratification behavior to the point of harm, and then ignoring or distorting the reality of that harm to allow yourself to continue the relationship. Yeah. So if you're drinking 1 or 2 glasses of wine a day, maybe it's a problem, maybe it's not. Let's look at your blood work. Let's look at your liver. If you've had a bunch of DUIs because of that, that's a problem. But it may be a tremendous benefit for some people who have a diversity of other sources of emotion management. So it is the singular nature. If every time you're stressed, every time you're exhausted, every time you're happy, every time you're bored, you're having a glass of wine, that is a singular pattern. If some days you go for a walk, other days you play a game of cards, you have a spiritual or meditative relationship, you have good human connection, and while I'm hanging out with my friends and I have a couple of glasses of wine, even if I get a little tipsy, no big deal. Does that make sense? So it's not about how much you consume. It's mitigated by, it's quantified by the harm. And then when you challenge people, if they are aggressively defensive, you are now irritating that wonderful little kumbaya environment that they've settled themselves into. And one of the things that we can tap into, oh, but I don't eat so much, but you're 300 pounds. It's like, that is not because you're breathing heavy air here in Florida that's a bit humid. So we've got to gently help people to recognize and connect with this. And then, look, we're all going to die. We're all going to die. The decision you then have to make is, okay, I've had 5 DUIs, but I love my alcohol. Here, take my keys. I'm going to keep drinking. Okay, that's fine. I mean, it's not fine in my perspective, but from their perspective, it's fine. It's a decision that they made. So we've got to work with the decisions that people make based on education, based on information, and it's individualized. What I love about the work that I do is I don't use algorithms. Every patient has unique interests, unique approaches, unique things that they can handle. And I'm going to meet you where you are, give you information, and share the decision-making process in a continuum. What I hate about diets is it's one sheet, here you go, off you go, I'm carnivore tomorrow. Garbage.
One size fits all,
yeah, it took decades to get here. Let's unwind this slowly to the extent you can. So I know I talk a lot, but that's kind of the discussion point there, that you asked me how I got here. And I'm continuing to learn more physiologically as well as psychologically.
Wow. Thank you. That's really, and I really like that approach. Tony, do you have a question for the doctor?
Well, no, I was just, it's funny because like a lot of times we talk about, it's like, it's not the carbohydrates, it's what happens after. Where do they lead you? Mm-hmm. When somebody breaks their diet and they go into 2 weeks of craziness, well, we have to take it for what it is, and I love, firstly, Dr. Cywes, I've been a huge fan. Like I've been following you for a long time, and I like how how you present yourself with, encouraging people to think, and I love it. So, yeah. As far as questions, I mean, Victoria, that was great.
Well, Tony, let me just add something to that. To you, what you just mentioned there, I call that a relapse. In the addiction world, that's a relapse. And if AA would not accept anybody that fell off the wagon, they'd have no members. Okay.
Yes. Yeah.
I've just come back from the place I was raised, South Africa, and I'll tell you, for a week I fell off the wagon. I've got certain ways, methods to recognize that, to own it, and to correct it. And I'm now back in a corrective pattern. Mm-hmm. But maybe I'm the only influence on the internet that sometimes trips up, because everybody else out there is perfect. But no,
seems that way.
I'm human. This is a lifelong battle. And I've actually created, for my patients and for myself, the concept of what I call OAC. You're going to make mistakes. Okay. You try not to. You try to implement habits and behaviors where you don't. But if you do, the earlier you own it, the better. And that is why, if you're a bit binary about your decision, then it's easier to recognize it rather than having an allowance. So an alcoholic is not allowed to, at least there's no allowance for drinking. One sip of beer is a relapse. But in the diet world, you can have a little bit, but not a lot. Now, how much is that? So we own the mistake. We analyze why it happened. And ideally, we come up with a corrective action plan. I can't undo what I did. I'm not punitive about it. Hey, I made a mistake. These were the circumstances, but I do not want to repeat that mistake again. So here are the strategies I'm going to implement to get me back on track, and to make sure if I'm in a similar circumstance, I'm less likely to do the same thing. So we put checks and balances into place. And that is an ongoing learning event. Isabella Cooper, who's an absolutely brilliant PhD at Oxford, she did a study to come to you, Tony, where she took a group of young women, all in fat-adapted ketosis, long-standing. I think 4 years was the minimum. And then she put them on the Eat Well diet. I think it's the UK diet of 264 grams of carbohydrates a day. And within a month, their blood work went off. But because they had habituated to a ketogenic type diet, carnivore-based ketogenic diet, within 5 to 7 days of getting back on that diet, their blood work improved. So the beauty about the human body is it is metabolically flexible. And it's when you persist in your relapse, that's the problem. That's why we talk about ownership. You try not to make mistakes, but the sooner you own it and recognize it, the sooner you can correct it. Yeah. But if you pretend and you kick that ball down the field, now it's 6 months. Now you got to reverse and restore all of those hormonal strategies.
Yeah, I think a lot of people get into that. Like, I mean, just for instance, right now, I think Peter and I are both lion diet, but the reason it's not because I want to be a lion diet forever. It's because I was kind of, eating a carnivore animal-based diet, I started to see myself getting loose, and I was like, okay, I gotta do something here to come back into myself. And, setting a thing for 30 days. And I mean, after 4 days, I feel great, but is it sustainable forever? Well, my life is going to dictate certain things. And yeah, it's interesting.
Right, and that is one of the corrective actions, whether it's Annette Bosworth's sardine diet, whether it's BBBE from Ken Berry, whether it's Lion. Those are all what I call eye of the needle corrections to reestablish routines, habits when you stray. Yes. And carb creep in that latitude will happen from time to time, especially under emotional duress. And, you may be working out every day, you go on a vacation, part of what happened with me. Now I'm getting back to my daily emotion management routine as well. So it's not just the eating, it's getting back on track. Yeah. In terms of where I go for emotional restitution. All of those things matter.
I love to have I'm sorry.
No, I love the carb creep. Sorry, that's one thing that you've coined a long time ago. And I tell that to my clients and friends, the carb creep is real.
Yes. So. And by the way, that's not mine. That's Eric Westman created that.
Okay, well, both of you guys are big
But I we've always got to give credit to the people that introduced this to us. The other, just while we're on this, and something that's intrigued me, I was listening to somebody who is doing his PhD on mitochondria. And it was very impressive what this guy was saying. What defines us as living humans? And it's an interesting question, because if you think about it, whether I'm alive or dead, this is me. I am no different whether I'm alive or dead. And what he said is what defines an alive human being, and we are defined by the flow of energy.
Absolutely.
So in my body right now, energy is flowing, and I'll come back to that. In a dead person, the only difference is energy isn't flowing. And one of the key things about, apart from the addiction, about metabolic health, which I do as a physician, is transforming and restoring a demand-based energy flow and counteracting a supply-based energy flow. In addiction, we are oversupplying in a continuum. So we are creating a tsunami of energy, and the human body hormonally and at a cellular level is trying to protect itself. How the human body protects itself defines the diseases we get. Okay? But ultimately, what we're trying to do is to restore mitochondrial demand for energy as the driving force behind energy flow. So when you're eating, snacking, and binging, you are oversupplying and defending. But now in my body, not now, but next week, because I'm restoring it, my mitochondria are going to say, hey, I need energy. My liver is going to produce that energy from available stores, fat and maybe a little bit of protein and a little bit of sugar in my liver. So the liver is always generating sugar. And it is regulated by glucagon, with insulin modifying glucagon, as opposed to the tsunami effect. The standard American or the tsunami diet is where insulin is trying to triage that energy into different places. It's getting the liver to take it up. It's getting the fat cells to take it up. De novo lipogenesis, where you're making new fat out of sugar. That's energy driven in the fat cells in the liver. Triglycerides are going up. The mitochondria, the cells are saying, no, let's block this insulin receptor. You produce a lot of insulin. You shove that sugar over that wall. You become fat. And when you cannot become fatter because you don't have enough insulin to counter that blockade, your blood sugar rises, and over time you develop diabetes. That's how metabolic health works. It's not difficult to understand. And what we're trying to do here is to restore a glucagon dominant environment, and yet nobody measures glucagon.
Yeah.
Yeah, that's right. Yeah. Well, I think education is key to all of this, because the four of us here understand the process behind what's going on. But
Victoria, I'm going to disagree with you a little bit. I'm going to disagree, and it's a jaundiced view on this. The education is there, the knowledge is there, the information is there.
Okay.
We have to decontaminate the politics and the economics.
I love it.
Okay.
Yes.
And the religious evangelism out of human nutrition.
Mm-hmm.
This is a religious evangelism. It is a political and an economic situation. The education, the knowledge is there. I just shared some of that with you.
Yeah.
You can go to ChatGPT and ask it any day of the week. It is the politics of this. So I just wanted to give some clarity to that, because that's the battleground.
Thank you so much. I wanted to ask you, I had the pleasure of meeting you at Meatstock 2026, and you gave a talk at which you hinted at some research you were doing with your patients. And I would like to ask you about that. I waited and I was rewarded. I saw the video you made on the CCTA scan and the research you're doing on that. I really would love if you would tell us about that and what you're hoping to discover through that research.
So you're talking about cardiac and heart disease?
Yes.
Okay. So, and this is also, again, part of it is political, part of it is algorithm driven, part of it is epidemiologically driven rather than physiologically driven. But Phil Ovadia, I just did a video. Phil is a cardiac surgeon, brilliant guy, one of us. And Phil made this beautiful statement, and it's such an important statement. There is not a single blood test that will tell you whether you do or do not have heart disease. There's not a single blood test that will tell you as a woman that you have breast cancer. There are blood markers that increase, that are potentially associated with risk. But the only way to know whether or not you have plaque disease, plumbing problems in your blood vessels of your heart, or if you are at risk have breast cancer, is to get imaging. And the problem is that most cardiologists are obsessed with an erroneous algorithm of surrogate blood markers, and they make an assumption of heart disease, and then are very emotive about using and prescribing what they call optimal medical therapy, which is a bunch of medications designed to reduce numbers, not alter your behavior, but to reduce blood work numbers in some mythical way, magical way, to prevent heart disease without ever looking to see if you actually have heart disease. So the shift in thinking is to say, okay, we want to look at that blood work and look at what those risks are, but the risks are irrelevant if you don't have heart disease. So simultaneously in parallel, let's image the heart, okay? So I may do a blood test to say, Victoria, you're the woman in the group. Let's look at your BRCA or HER2 gene, which we know is associated with a higher level, the Angelina Jolie gene, if you know what that's about. Let's look at that blood marker, but let's also get a mammogram to look to see if you've got breast cancer. And I know that Zoe Harkin will tell you that's a controversial statement, but the point is, let's look to see if you have heart disease. If I've got a 0 CAC score, I don't care what my blood markers are.
Me too.
Okay, at least in terms of the context of my heart disease. So image the heart first. And Art Agatston, who's one of us, he spoke at Low Carb USA in January of this year. This gives a great talk. He created the CAC score, which is a quantification of the amount of plaque that you have. It's an early screening test. Yes, you have heart disease and it's serious or it's not so serious. Once you have a positive CAC score, which is the screening test, okay, then we can go on and quantify that or look a little bit more deeply at that. Historically, the risk was associated by getting you to run on a treadmill or speeding up your heart and looking at the electrical system of the heart. And if there were electrical problems, EKG or electrical problems of the heart, once you sped up the heart, it means, coming back to the mitochondria, okay, let's just deviate for a second. There are two things that the mitochondria need, and the mitochondria are pretty much the only places where they use a lot of this. Number one is energy, glucose, fatty acids, ketones. But number two, which nobody really talks about, is oxygen. And in heart disease, the lack or the decrease of oxygen supply to the heart muscle can be detected when you speed the heart up electrically before you are symptomatic. That's what a stress test is.
Okay, that's what I was just going to ask that. That's the stress test. Because
that's the stress test. And there's a variety: treadmill stress test, nuclear med, echo, MRI stress, PET CT, variety of, there's 6 different modalities for stress. Okay, but they tell us your heart is under strain, you're at risk for a heart attack. We need to maybe intervene. So a better, more objective measure, once your CAC score is positive, to get a more detailed image of flow across that heart, okay? The best test by far is an invasive coronary angiogram. The problem is it carries risk with it.
Yeah.
It carries substantial risk. So the layer underneath that, the next best test that carries almost no risk, some radiation, some dye, but carries no risk, to tell us whether or not we should do a cath, is called a coronary CT angiogram.
Yeah.
And they inject some dye, very similar to CCTA, but now we get a better look at the plaque, because with a CAC score, all you're measuring is the calcium. Plaques have 3 levels: calcified, fibrotic, and fresh. So all we're doing as a screen is looking at the calcified portion. So if you think about the old photographs that we took with cameras and film, that would be like looking at the positive picture. The CCTA gives us the negative, so it gives us the opposite. It shows the lumen of the vessel, shows restriction of the lumen, so we can see how long the restriction is and how tight it is. And then we can quantify the flat FFR, the fractional flow reserve, what the flow looks like from above to below the lesion. And if there's a decrease, a significant decrease in flow, you're at direct risk for a heart attack. And a CCTA with FFR tells us, okay, dude, you need to go to cath. And every single day I'm diagnosing that. Now, in addition, we have another test that has become clinically robust called a Cleerly or heart flow AI plaque analysis. And now we're using AI and certain density evaluations from the CCTA to look at what fraction of your plaque is calcified, what is fibrotic, and what is fresh new plaque. And also the Cleerly will tell us additionally about flow as well. You're at risk for ischemia, you're not. None of these tests are perfect. They all tell us you need to go to cath. But here's how I use Cleerly now. And I've done between 200 and 250. Art Agatston's done a lot more. And I'll use Cleerly in my patients with positive heart disease. But here are the results. When we look at the Cleerly study in people that have plaque on the standard American diet, there's between a 5 and a 10% amount of fresh, soft, active plaque. It's very low density. That's where the cholesterol is accumulating, but the cholesterol is not causing that. It's responding to inflammation. The fibrotic plaque is much more dense and hard, and the calcified plaque much more dense. So if, Tony, you're on a carnivore diet, now you're BBBE or you're Lion, and you've got some calcified plaque, but your CAC score went up.
Yeah.
We don't know if that's a bad thing or a good thing. It may just be that fibrotic compartment that is further calcifying, which is good, it's stabilizing, or it may be fresh plaque that is making new plaque. We don't know, but the Cleerly is allowing us to see that. So standard American diet, we're seeing a substantial percentage of soft plaque in people with heart disease. That amount grows by around 3 to 5% per annum. If you take a statin, it doesn't change the amount, but it slightly reduces the rate at which it increases because you're reducing the amount of cholesterol in that plaque. But that's a visual change, not a physiologic improvement. Okay, so the optics are better, but it's not making a difference. In my personal experience and in conversation with Art Agatston, when you've been on a low carbohydrate, carnivore-based or low carb diet for 8 to 12 months, and your blood work shows a reduction in normalization of the factors that causes your diabetes and inflammatory markers, the highest fraction I've seen in those patients of soft plaque is 0.4%.
Wow.
So we see an absolute reduction in the volume of soft plaque. And it's not because cholesterol has changed. Their cholesterol and the LDL has gone up, as we know. Yeah. So in the face of an elevation in cholesterol, we're seeing about a 20-fold reduction in the amount of fresh soft plaque. No medication. Maybe a GLP-1 for some people, but we see that reduction. And the GLP-1s affect that as well.
Well, so, that's information. And it's so nice to hear you explain this in context, because that's what I find with a lot of, like, we'll say, I'm not going to mention any names, but social media doctors that are preaching the old school, like, you need a statin, it's cholesterol, it's all this. They don't give you any context. They just say, this is what you do, this is what you need, don't listen to them. And I mean, when you're laying it out like that, that makes so much sense.
Yeah.
It's a process.
And I think, that is just really a return to physiology away from epidemiology. And epidemiology is associated with disease potentially. But so there are some people with a very high LDL, very high cholesterol, very high ApoB who have a lot of heart disease. Then there are people like me who have a very high cholesterol, very high LDL, very high ApoB, no heart disease.
Yeah.
I'm never going to see a darn cardiologist. They're never going to see me. Okay? If you do not drink alcohol, it's unlikely that people at AA are going to see you.
Mm-hmm.
It's pretty darn obvious. So it skews the metric when all they see is people with high LDL and heart disease, LDL, and then they make the mistake, the statistical mistake of assigning causality to, at best, an association. That's where they get themselves into trouble.
I have a question for you, Dr. Cywes. Like, this is because we often talk about feeling good. Feeling good is a great indicator of your health. I mean, feeling good tomorrow is if you're starting to progress the wrong way. But how many people, if you don't mind me asking, well, in that you've seen when they've had these problems with plaque and they've had these tests, are they reporting symptoms, or are they just like, because that's what I feel like in the social media space, is that they're kind of saying that we'll use LDL as the marker. If you have LDL, you're going to have that Widowmaker jammer. Like, this is the problem. So
let's break that down. Very, very intriguing questions. There is no doubt, and this is from my medical school, and it's still being taught in medical school, that smokers, or I'm gonna change that up, people that consume nicotine, whether it's pouches, whether it's vaping, it's not just smoking, it's nicotine. Nicotine causes vasoconstriction and endothelial damage. So typically, in the old days, nicotine users would become symptomatic with severe heart disease, and we could potentially look at symptoms as a reason to intervene. Simultaneously, and I was in medical school in the 80s, even at that time, we were all told that diabetics have silent heart attacks. So hyperglycemia that does not cause vasoconstriction is typically asymptomatic. Now, another paper will tell you that 64% of women who have a heart attack find out that they have heart disease while they're having their heart attack. It is silent before that. So in the modern era, where we're shifting to a certain extent away from nicotine as the primary driver of heart disease toward the commonest form, there's 7 causes of heart disease, of plaque disease. And when I say plaque, it's the plumbing, because there's electrical and other things. But the dominant one right now is hyperglycemia. You don't even have to be diabetic, okay? David Diamond will tell you that an A1C of 5.556, a male doubles their risk of cardiovascular disease. Females is about 5.7, normal being 5.2. Having said that, chronically elevated blood sugar will drive that heart disease, but because there's no vasoconstriction, you don't typically get symptomatic until you have the event.
Okay.
So no, symptoms are no longer something we can look at. At least we can look at as a predetermining factor to go further. Yet, the healthcare system, certainly here in the US, I don't know what it's like in Holland or Canada. For example, if I'm going to order a test, the insurance company will only authorize the test on the basis of symptoms.
Yeah.
Which is lunacy. So I'll send somebody with, I had a patient this morning with a CAC score of 2,200, 68 years old, never had an image before. I did the imaging, saw it, and I said, oh, hell, we don't know what's going on here. Asymptomatic, carnivore, or carnivore-based, but we don't know what's going on. Try to order the CCTA, insurance blocked it because it was asymptomatic. So I said to him, dude, go and run up, now let's go back to Toronto, go and run up the CN Tower, and when you get to the top, decide if you're short of breath, and tell them that. It's frustrating. I don't want to be fraudulent.
You know what?
It's
funny that you say that, because my mom went through this. Like, she went low carb, did this healing path. She's been a smoker for 65, 70 years. So she was out of breath. We fixed her diet. She got better. But then I was telling her to ask the doctor for a CAC score for peace of mind. Like, it took her a year to get one. She got qualified. She went into the office, and the cardiologist was like, you don't need to be here. Why are you here? You need to be on a statin. She got the test. She had an elevated calcium score. The doctor freaked out and then was like, you need to be on these drugs. You can't be doing this diet anymore. And my mom was just like, I'm so blessed that she was actually listening to me. I was like, Mom, this is information. We need to act accordingly. And had the angiogram, passed the stress test. Everything was fine. All these things that they said, there was no blockages. Like, you're not in any serious danger. And this was our system. I was like, It took her 2 years to get all this sort of for just peace of mind. And
she's lucky that she didn't have an event during that time.
Yeah.
That's the challenge. That's the challenge.
She's in her late 70s. And this is like, what? Yeah. Anyway.
So just two comments there. Victoria, when you asked me about what's CCTA that led to this discussion, the benefit of CCTA, you see, stress tests typically have to be done by cardiologists. Mm-hmm. So they own that space. CCTAs are typically radiologic studies that can be read by radiologists and their associated cardiologists. So what has shifted for me, and this is so important, is that my whole philosophy, everything I do is prevention. It's preventive. So I am an expert in preventive medicine. Cardiologists are therapeutic and they respond to events. So if I can push the therapeutic intervention of cardiologists further down the road by doing the preventive workup and kind of wrapping those patients up with a little bow and saying CCTA is positive, clearly shows, and then going to the cardiologist. So I send patients to cardiologists, to an interventional cardiologist, to say, this person has a low FFR, 0.73 I had one today, high CAC score, please do a cath. I'm not asking for their opinion. Now, obviously, they're going to give that, but these people already meet the criteria. I'm the gatekeeper for the criteria. So, because they do not practice preventive care, they practice therapeutic care. And Peter, by the way, I have a lot of Dutch patients, and it's difficult to get CAC scores. But you know what you can do?
Here, I would love to have one. I've had very...
Go to Belgium.
Yeah.
My patients get their GLP-1s and they get their CAC scores done in Belgium or in Germany, but Belgium is the place they go to. So just a little. And again,
let me briefly tell you that I was in extensive research on my cholesterol. They did spectra measurements and all these things. They went to South Africa to measure it, but the only thing that they didn't do was a CAC scan or anything. So
and quite frankly, it was the only thing they needed to start with.
Yeah.
Because if that's 0 or if that's below 80 or 100, nothing else matters.
Yeah, in Canada, we just go down south to Washington State. It's $100.
Yeah, and I mean here in Florida, it's $97 US.
Yeah.
But if you are international, you can go to South Africa. You can walk in and get it done there very inexpensively. You can go to Thailand. You can go to Vietnam and India. India, you can walk in, and as long as you have a reputable place, it's cost effective and very high quality. Remember, a lot of our studies are being read in India anyway. All the mammograms are being read in India anyway. It's not an indictment. But those are places. So more and more, as we can no longer rely on the conventional healthcare system. I just had my blood work done in South Africa last week. Okay. Cost me a fraction of what I did a video on that on my YouTube channel, a fraction of what it cost. So and you know what? Have some fun while you travel. Go and visit them.
Really, it's a holiday.
Doctor, sorry, go on, Victoria.
Thank you. Doctor, will there be a research paper on what you're doing, and will you relate it to a low carb diet?
Yeah, no, absolutely. There will not be, from me, any peer-reviewed publications. However, we are currently writing the guidelines for Nutrition Network and for SMHP, Society of Metabolic Health Practitioners, the new cardiac guidelines. However, the reason I say there will not be a peer-reviewed paper with all the blood work that I have and all, because it's just too cost ineffective. And if I put any of this work out in front of so-called my peers, the first thing, because their cognitive dissonance is such that what I'm doing is I'm killing patients, obviously, because I clash directly with them. So as human beings, they are not going to necessarily agree with my hypothesis. I'll give you a perfect example of how this worked. I mentioned Isabella Cooper a few minutes ago, and Isabella did a PhD at Oxford, and she wanted to take a bunch of sick patients on the standard UK diet, put them on a ketogenic diet, and see what improved. But in order to do a human study, you've got to go through what's called an IRB, Institutional Review Board. And the IRB told her, that they will not allow her to harm or kill her patients. And the ketogenic diet is going to do that. But the beauty about Isabella is she flipped that upside down and she said, okay, let me take a bunch of carnivores or ketogenic fat-adapted people and put them on the UK diet. And instead of seeing improvements, seeing how much worse they got. It was brilliant. And I refer to Isabella's data often with my patients. So no, you won't see peer-reviewed data from me. And by the way, if you look at a carnivore diet, it is the single fastest way to improve metabolic health because there's no carbohydrates, high fat, lean protein. However, because there are no medium or long-term studies on the carnivore diet, there is no support for that. So when more and more people are going to AI to look for the data, and I just had this conversation with ChatGPT a couple of days ago, is that you won't find any support. We're not saying that a carnivore diet isn't the best, okay? Because the lack of peer-reviewed data doesn't tell us it's not a problem, but we cannot categorically say it is. And I've got 30,000 patients in my time that tells me it is, but none of it is published. So the challenge is to look at physiology because the studies are just not out there because they're cumbersome, difficult to do, and the cost is ridiculous.
And it comes back to what you said at the beginning, politics and,
religion and society.
And, go ahead.
I would like to suggest to all of us here, I've recently discovered a replacement for ChatGPT that actually looks up citations of peer-reviewed and other medical information. It's called Perplexity. It's free to use, and it will bring you those citations, especially if you know how to word your inquiries. So look at Perplexity as a replacement for ChatGPT because Chat doesn't go out and Claude doesn't go out and get it, but this app will pull them in and it's specifically designed for that.
Well, okay, and you're absolutely correct. Perplexity is the best research tool. Claude and Grok are more aligned with our way of thinking. The reason I use ChatGPT is because ChatGPT has what they call physician status. So you apply for it. Okay. There's quite a detailed set of criteria that you have to meet. But I'm on the clinician status for Chat, and it gives me all the references.
Do you argue with it?
Yeah, I don't get that.
As others do. And then the benefit for Chat is it's HIPAA protected, so I can share information and get, and it isn't available out there.
Interesting.
Plus, also, I have been able to educate Chat. I've had this big fight with it. I said, dude,
so you argue
all because you don't have papers on Carnivore.
I do too. I tried it.
Read it that way. So I'm a big proponent of AI. It's not always right. It does hallucinate, but at least it gives us direction and corroboration. But you've still got to be inquisitive. Don't always believe it if it's not believable.
Yeah.
Doctor, you mentioned in passing that some of your patients are using GLP-1s. Tony Stewart has been coaching people who are coming off of GLP-1s. Can you tell us, we have seen your videos on retatrutide and use of GLP-1s, and we understand your position on this, but could you explain to our audience how you prescribe and deal with GLP-1s in your practice?
First of all, the foundation is always a ketogenic carnivore-based diet. Beautiful. Always, okay? Yeah. Now, in India, there's 200 million diabetics. They're all Hindus, so they're mostly vegetarian. I've got to work with them, so I'm going to meet them where they are. Having said that, the foundation is always to start at root cause, which is the mental health space, the miseducation, and then the dietary approach. Not everybody can be perfectly carnivore.
Yeah.
Okay. Some people are more permissive. Their intent is strong, but they struggle. They bump their heads. Something goes wrong. If you've tried to quit smoking 20 times and you're committed to quitting smoking, but you're struggling, and nobody's going to tell me don't use Chantix. If you're on fentanyl, of course you're going to use Suboxone or methadone to help you to come off, but it's bad to use GLP-1s. And that is way too evangelical. Of course, if you can sustain a ketogenic diet, you don't need other medication. Mostly you don't. But if you're struggling from a baseline relationship change, then using GLP-1s low dose as accelerants to what you're doing, don't outsource to them and not change. Use them in combination. I'm working on changing my lifestyle. I'm struggling. I want to see positive results. I don't want to be despondent. We use those GLP-1s to help us transitionally for 90 to 120 days. And we'll talk about, it's not about deprescribing. The other indication for the GLP-1s is if you have significant endpoint disease. I already mentioned earlier on that they are 20 times better, 20-fold better at reducing soft plaque than statins, but together with the diet. So if you've got bad heart disease, if you're on 4 blood pressure medications and you're stranded in your blood, it is an incredibly powerful blood pressure medication. Okay. If you've got infertility from PCOS and you're now 40, 42 years old and there's urgency to get pregnant, a GLP-1 accelerates that process. So there are, on Alzheimer's, I'm using GLP-1s now in my Alzheimer's patients together with a ketogenic diet. Stephen Kinane in Sherbrooke, Quebec is the master of this. In my Parkinson's patients, I'm starting to use it. In cancer, we're using it. In my type 1 diabetics, the American Diabetes Association says it's contraindicated in type 1s. Why? Because they see all the benefits. Lower insulin utilization, lower comorbidities, better control of blood sugars. But because they didn't change the amount of insulin they're using, they saw higher hypoglycemia. GLP-1s are bad. I use GLP-1s in 60+% of my type 1 diabetics with a massive reduction, about a 1/3 to 2/3 reduction in insulin utilization, standardization of their blood sugar, and improved comorbidity metrics. So all of those patients, it's excellent. You've heard me talk a lot about insulin suppression in carnivores.
Yeah.
Well, insulin suppression is a lack of triggering human GLP-1 and human GIP in the upper intestine that causes the release of insulin. So if you look at Paul Saladino, the Paul Saladino story is one of biochemical followed by clinical insulin suppression. No matter how much carnivores wish that away, that's a reality. I see that every day in the blood work I do. How do you correct that? You want to trigger GLP-1s. Now, if I don't want to, if I'm afraid of using sugar to do that, microdosing GLP-1 is an excellent way to go. Annette Bosworth's using it all the time for her rookies, and it works phenomenally well without the side effects. So there are multiple benefits to GLP-1s. Now, just before you go, Tony, you also mentioned you're coaching people to deprescribe. Yes, you use it regularly to gain control, to have a positive effect. But so the second biggest argument I have with my patients, who I think could benefit, is to try it. The single biggest argument I have with my patients is when it comes time to stop, to actually get them to stop because they fall in love with it. However, what I then do is I say, okay, let's stretch the dosing. Instead of dosing every 7 days, let's go every 10 days, every 12 days. If you're premenopausal and you have a rough week on your period, let's use it for that week. Let's not use it on other weeks. If I'm traveling, let's go ahead and use it while I'm traveling, but don't use it at other times. So the flexibility and the empowerment of the patients to have it in the fridge and use it episodically when they need it to protect them from bad relapses is ideal. And the ideal is to keep it in the fridge and never need it, just like Tylenol or acetaminophen or paracetamol in Holland for a headache. You're not going to take it every day, but when you have a headache, you use it. That is the ideal way to use GLP-1s long-term when you find yourself getting into trouble. Now, if you are perfect like all those gum flappers on the internet,
that's what I was going to ask you.
Okay. I've also chosen not to use it because I can rely on myself for getting on track. Quite frankly, it would have been better for me to have used it while I was in South Africa. It would have mitigated the degree of my relapse. But I've also been down that road and I could correct myself fairly easily. But if I got into trouble, I would have no compunction to use it.
Okay. Because that's kind of like, I just saw your video and explaining Red True Diet, and like you just hit the nail so many times, because what I feel the problem is in the mainstream now is it's gone so far from a consultation with your doctor and managing it. They're available now. You're seeing marketing in the malls. So do you think those success stories are going further than, you know, what you're doing? And that's the thing that scares me is I've seen people, all my friends are doing it. I'm going to do it too. Like that's crazy.
Right. Well, okay. Let me broaden this a little bit, because my biggest fear and my biggest concern within our own space, every clinician out there is investing in peptides.
Yeah.
We have become peptide princes and peptide princesses. And it's not just the GLP-1s, the GIPs, the glucagon agonists, the redders. No. It is this whole host. And every day I get patients who are on peptides on the gray market, or are interested in MOTS-C for my mitochondria, BMP 157 for inflammation, Tesmorelin. All of these things are now available. And I had a patient last week. She's spending $8,000 a month on peptides. She's 39, 40 years old. Okay. It is ludicrous what people are outsourcing to. This is the new opioid generation. Yeah. Whereas, 10, 20 years ago, we had this nurse practitioner, PA or doctor in some hotel room or some little corner office in a mall. Oh, I've got back pain. Here's 1,000 oxycodone for you. Yeah. Now we've got all these people going into these little peptide shops. Oh, I've got inflammation. Oh, I've got brain. Oh, here's a peptide for you. Here's a peptide. And none of them are studied or approved. I think there's huge value to knowing more about the peptides, but outsourcing to peptides as a first line is nuts.
Yeah.
Okay. And I think we're seeing that more and more. So it's beyond just the GLP-1s that started it, but it's this whole evolution of peptide hormones that is a concern. And I don't know where it's going to stop.
Yeah. Okay? That's kind of the fear. And I just, when I started what I'm doing, it's for the people that are sort of willy-nilly, laissez-faire. Like, it all starts with metabolic health and your health status first. And people that want to lose 5 pounds because of vanity, do you understand what you're getting into? Like, you have to be, and that's what it's.
But you see, ultimately, Tony, the majority of the use of even the GLP-1 type drugs is cosmetic.
Yeah.
Okay. My job as a physician is to look beyond the cosmetics, maybe leverage the cosmetics a little bit to get them to try it if they've got bad heart disease, bad diabetes. But my use of this drug is as a medication, not as some way to avoid plastic surgery or bariatric surgery. So, but I also understand that the cosmetics matter.
Yeah. Yeah.
You talk about happiness before. The cosmetics matter to most people. Okay. And matter to me as well. When I was 300 pounds, I hid away from everything. I'm not perfect. I'm still a fat guy, but I've lost 107, 110 pounds, and I'm comfortable having my photograph taken. So the cosmetics matter psychologically, especially if you are all addicts, have a poor sense of self. We're all emotionally fragile.
Yeah.
And the cosmetics do matter. You can't underscore that. Okay. Look at all the influencers on the internet, even in our space, who run around with their shirt off.
Yeah.
That's not me. You're not going to see me do that. Okay.
Yeah. Something that you touched on, especially in your video, was something that I've been sort of trying to encourage people to look into, is the micronutrients, and specifically B1. And you mentioned that you've seen berry in some of your. Do you mind talking a bit about that? Because I think that's
if you don't look, you don't see, and IKYK, if you know, you know. B1 is a very, very important cofactor vitamin in a number of processes. And in carnivore or carnivore-based patients, there's a higher requirement for B1. And if you're not meeting that supply in your diet, you can run low. Now, most people will start out low and not replenish it. So what we do is we'll replenish and then have them eat eggs and maybe some dairy and get the other sources. But nobody, or very, very few people, ever measure B1 levels. I do it now routinely, and it is profound, no matter how healthy you think you are. In fact, the healthier you are on a carnivore diet, the more likely you are to have B1 deficiency. Forget about GLP-1s. But what happened is I started to recognize it in my patients on Reda and the GLP-1s, especially the higher doses, because they weren't eating very much. And we saw a decline in that. Plus, their protein turnover becomes greater with glucagon. So I look at B1 all the time, and I must have had 3 or 4 patients today where I prescribed benfotiamine. What does B1 do? Number one, all you do is go to your favorite AI channel and type in cardiac beriberi. B1 is vital for the heart. Most people don't know that, okay? Yeah. The commonest micronutrient deficiency B1 in diabetic neuropathy is B1. And diabetic neuropathy is not just peripheral neuropathy of the legs. We talked earlier on about plaque disease. Well, electrical disease of the heart, atrial fibrillation, arrhythmias, vagal nerve, that's a B1 has a role to play there. If you've got, I'll make a strong statement, SIBO is garbage. Okay. The majority of people with so-called SIBO diagnosis have intestinal neuropathy. Okay, intestinal neuropathy, vagal nerve neuropathy, and B1 is a large factor in that. If you've got gastroparesis, that's a B1 issue. Okay, why? Because a lot of those are diabetics. And on the GLP-1s, what do they get? The gastroparesis. So just look at your B1, and it's very simple to replace it. The other thing also is spinal cord issues, B1 and folate. Okay.
Well, I'm a gastric bypass patient. I had Roux-en-Y in 1999, January. And I've known that I've been low on B1 through testing over the years. And I thought when I became carnivore that I could replace it with food, and because there's thiamine in pork.
Quite the opposite.
Yes. Wow. So yes, I still take a supplement. Yeah.
Several reasons. Number one, you're eating less because you have had a bypass. Number two is your absorption is messed up. And number three, and with all due respect, that's what a bypass does. I'm a bariatric surgeon, but I'm somewhat anti-bypass. And again, you can't undo what you've had. And in 99, it was a different story, but we know better now. But the other part is also on a carnivore diet, your requirement for B1 increases. So you've got 3 hit points. And, the average bariatric patient takes their supplements for no longer than 3 months. Well, you're going to have that surgery until after you die.
Well, yeah, it's been 27 years.
Right. But kumbaya, I'm going to take the medication. But within 3 months, they've lost a lot of weight. They're feeling good. They stop taking it. And then they come in because they're getting foot drop, or they've got other metabolic issues from the micronutrient deficiencies. And when we look, they can be pretty profound.
Wow.
So it could be a supplement for a carnivore dieter?
It should be. Well, no. Let me back. It should be measured in anybody on a carnivore diet. Measure it. If your level is 20, you don't need it. But if your level, and I had 3 patients today, unmeasurably low, below 6. Okay. They didn't know.
I have a question about this, because I also read that diabetics have risk of lower B1, but is that because of hyperglycemia? Or, for example, for me as a type 1 diabetic, do I also risk to have low B1?
I think if you're human, you are at risk. Okay.
Yeah, sure.
And the risk may be high or low. The point is, I don't care who you are or what health issues you have. I'll come back to that in a second, Peter. Measure. Get the test. It's not a difficult test to do. Just check it out. And if you're okay, you're okay. But nobody ever looks. What type of type 1 diabetic are you?
The common one. So
what is your
late
A1C?
onset? But
what is your A1C?
5%.
Okay, so you are not a diabetic.
No, effectively not. Yeah.
No. You have insulin deficiency. You don't have diabetes. Very important distinction. Diabetes is quantified at a chronically elevated blood sugar above 6.5. If your A1C is below 6.5, you technically, doesn't matter if it's 1, 2, LADA, doesn't matter. You do not have diabetes. You have insulin deficiency. And in you, the job of insulin is not to regulate your blood sugar. The job of insulin is to regulate glucagon. Does that make sense?
Yeah, and in fact, my insulin levels are higher than in most non-diabetics, because I inject it here. So it has to go higher up.
Yeah, but the other part also is you will never, ever become insulin suppressed.
No.
because the problem with insulin suppression is a lack of insulin. Well, you're giving yourself insulin.
Yeah.
So I've got a large population of type 1s, and we manage them on very much using the Bernstein approach. But I mean, the fact that you've achieved that. Now, you know what the first thing an endocrinologist is going to tell you? Your A1C is too low.
Yeah, no, definitely. Yeah.
It's nuts.
Go figure, eh? Right.
It is absolutely. So my oldest type 1 has been type 1 now for 64 years. Okay. And his quote is that the number one enemy of a type 1 diabetic is their endocrinologist.
Oh, God.
Because the endocrinologist is purposefully causing disease by allowing you to run blood sugar high and give you sugar to eat or tell you to eat sugar.
You need your carbs, Peter.
That is malpractice.
Yes,
Yeah,
it's
no, it is,
reprehensible. It's attempted murder.
You do not have diabetic comorbidities if your A1C is below 5.4, 5.4, 5.5.
No.
And except for possible hypoglycemia, which you can mitigate with ketones.
The only thing that I fear is that my insulin levels in the periphery are a bit higher than in other people. So it, of course, avoids the insulin, how do you call it?
Okay,
suppression.
so let's go down that road. Let's go down that road, Peter, because what you're describing here is somebody who is obesogenic, whether you're diabetic or not, just like me, okay? Even if those insulins are running high, what are the three diseases that you are more vulnerable to? Alzheimer's, cancer, and autoimmune disease. But if you mitigate those, you should be able to, you as a type 1 diabetic should live longer than anybody else in this country or in the world, obviously, that is metabolically challenged, because I have to wait for my pancreas to respond. You can look at a CGM and respond.
I can pre-bolus.
Yeah. But the problem is that diabetics are shorter and sicker, not because they're injecting insulin, but because of what they're told by their endocrinologist.
Yeah.
Crazy.
Yeah,
Wow.
it is. Yeah.
Well, doctor, we want to be respectful of your time.
Yeah, I do. I just want to tell Peter one other thing.
Yes.
Try a low-dose GLP-1.
I tried allulose actually, and that already helped
allulose
me
may work
a
a little bit. It could, but you see, a low-dose GLP-1 is going to reduce your insulin requirement. Why? It does nothing for insulin. You don't have any. But the GLP-1s, they do two things. They increase the release of insulin, but they block glucagon. So if you can measure your glucagon, I bet you it's high. The role of insulin in you is to block glucagon. Well, the GLP-1s do that, so you need less insulin.
Yeah.
And again, it's not, you notice how immediately you're afraid of that. That is I'm not going to use the word bullshit, but that is the trauma that our space has caused for really good medications.
No, I agree with you, because type 1 diabetes is an artificial situation, right? So there is deficiency of insulin production, so the glucagon is not blocked. So in that sense, it's just like taking insulin. You're trying to correct something that is truly artificial. I'm in an artificial situation. I inject insulin under my skin, so the insulin near the liver is always a bit too low compared to what it should be.
I wouldn't necessarily go down that rabbit hole. Your insulin requirement is a little higher, but it can be mitigated by other, because everybody has other hormones that help to manage. It's not just insulin doing the heavy lifting by itself. There are other hormones that mitigate that relationship. So there's a very interesting, you can go to, again, the AI studies and things like that, and just look at if you had zero glucagon, if you could block glucagon, as a type 1 diabetic, you don't need insulin. I'm being deadly serious. I'm being dead serious. Go to AI and read up about that. No glucagon, no requirement for insulin, even if you do not have a pancreas.
Wow.
Okay? And once you understand that, then you realize what you're trying to do with your insulin. Does that make sense?
Yeah.
And
we only have the insulin to pull the lever.
Yeah, those are so a GLP-1 medication that modifies low dose, very low dose, microdose, will help you to reduce your insulin and reduce the risk of Alzheimer's, cancer, and autoimmune disease, which you're now vulnerable to because of the slightly higher insulin levels. So again, we've got to think about this not from an emotional perspective, but from a physiologic perspective. And the problem in every arena of healthcare is there's a lot of emotion. There's emotion about statins. There's anti-emotion against GLP-1s in our space. There's emotions about all of these things. And we want to be less emotional and more objective about how we can optimize our health.
Yes, that's my final question here is what would you recommend? What advice would you give someone who's looking to improve their metabolic health? What is a good first action step for them to examine? Would it be food? And you mentioned emotions. Would it be screening, testing? Where would someone start to get?
The first place to start is decide whether you are willing and desire to change, because it's difficult, it's tough. Second thing is meet with somebody that can give you objectivity, because when an addict looks at this, the first thing they're going to do is defend. Even if you want to change, you're going to defend. So outsource that to somebody that you trust, that is not judgmental or critical of you, but can maybe conflict a bit with some of your deeply held beliefs. I've got a little statement here on my desk that says, my job is to both reinforce and help you to alter behavior patterns. And ultimately, my job is to help you to set expectations through building trust and unlocking a locked-in mindset. I've got that written down right here because that sits on my desk and I have to refer to that as I work with my patients. Because I don't want conflict, I want camaraderie. But it's very difficult to do yourself. I know that Peter's sitting there saying, well, hell no, I'm not going to try GLP-1. But in the next 3 days, he said, hey, let me do that little experiment, maybe. So the point is I've got to resonate with you over time and help you to undo your cognitive dissidence.
Wow.
And it's very difficult to do yourself. It's easier to do with somebody if you can trust them.
Yes, hopefully. Yeah.
That makes
Well,
sense.
thank you. Thank you for a marvelous interview. We really appreciate all the valuable information you've shared with us today. Thank you, Doctor.
I appreciate that. It's great what you guys are doing. And to have this all over the world is fabulous. Good stuff.
Yeah, we're
Well,
trying.
thanks, Dr. Cywes. You're an inspiration, truly. And it's nice to know that there's help out there in the medical space that, and
Yes.
I got to ask, do you take Canadian consults?
All the time, yeah.
Awesome.
All the time. A lot of patients in Canada.
Awesome.
Yeah, you already said that you had Dutch patients.
Oh yeah. My whole little the Orange Army. I've got the whole lot. I love my European patients, and your access to healthcare and everything is just so vastly different to what we have here.
Yeah.
So, all right, guys, I do have to jump, but
thank you very much.
Thank you very much.
Okay. Thank you, guys. Bye-bye now.
Loving memory
Bye.
of sweet companion and family member, Rocky. For 16 years, you filled our lives with unconditional love, loyalty, and joy. You leave behind a quiet that only you could have filled. Every walk, every welcome home, every gentle presence by our side meant more than words could say. You will be deeply missed, dear friend. Rest peacefully, knowing you were loved every single day.